Welcome to the launch of the Lancet Commission on Diabetes. This commission was chaired by Juliana Chan with Edward Gregg in partnership with the Chinese University of Hong Kong, the Hong Kong Institute of Diabetes and Obesity, the United States Centers for Disease Control and Prevention, and with the help of the Croucher Foundation, for which many thanks. This report represents 4 years of incredibly hard work and could not be better timed, not only because it is World Diabetes Day on November the 14th, but also because next year in 2021, we will be celebrating the centenary of the discovery of insulin by Banting, Best and MacLeod at the University of Toronto. Now, we are today facing a challenge, and that challenge is not a pandemic. It is, in fact, a syndemic, a synergy of epidemics. One epidemic is certainly the SARS-CoV-2 virus, but another is the epidemic of chronic diseases, including, of course, diabetes. And both of those epidemics, the virus and chronic diseases, embedded on a background of deep inequalities in our societies. The idea of a syndemic unites the social with the biological, and diabetes is an absolutely central part of this story. We simply will not be able to control this coronavirus without a broader vision for what we mean by pandemic preparedness. And that broader vision means that we have to have a strategy for preventing and treating diabetes. This commission delivers that strategy. And this launch today will introduce you to the chairs, our commissioners, their key findings, the messages and the recommendations around closing the gap in prevention, in knowledge, in care, and in data. We will then have a discussion with our key partners at the World Health Organization, IDF, and PATH, and explore opportunities for implementing the findings of this commission. We hope that you will join the movement that this commission aims to trigger and that we are launching today. It truly is an extraordinary opportunity. So join me. Thank you very much.
Thank you, Richard, for that very motivating and energizing opening remark. I'm Juliana Chan from the Chinese University of Hong Kong. Every day, thousands of people are dying with diabetes silently, with too little being done and often too late. The pandemic of COVID-19 has unfolded the vulnerability of people with diabetes during acute emergencies, in addition to the very high risk for multiple disabilities and premature death. While insulin is life-saving in people with type 1 diabetes, type 2 diabetes can potentially be avoided, and diabetic complications are preventable and treatable. The lifelong nature of diabetes calls for self-management, which requires not just access to medications, but care and education. Since 2016, 44 global experts and researchers have reviewed, critiqued, and synthesized evidence to propose an integrated societal and personalized solution to reduce the burden of diabetes and non-communicable diseases. By ensuring access to medications to reduce blood pressure, blood cholesterol, and blood glucose, and transforming the way how we deliver care using a team approach aimed at gathering data systematically and use the data to stratify risk, empower patients, and inform shared decision-making, we can prevent heart disease, stroke, kidney failure, and death by 40 to 60%. In 2017, 1.6 million people were living with type 1 diabetes. Over 14,000 people died due to inadequate care, mainly in low and middle income countries and underserved communities. By ensuring these young people have access to insulin, blood glucose testing strips, and education, over 80% of these deaths were preventable. In the same year, 217 million people lived in 10 lower and middle income countries, accounting for 50% of the global population with diabetes. The majority of these people were not diagnosed, treated, or managed. By diagnosing at least 50% of them and ensuring that 70% of these diagnosed people had access to medications, continuing care, and education, we can prevent 800,000 deaths in 3 years. However, to save these lives, we need concerted actions from policymakers, payers, planners, practitioners, and patients to work together to translate this evidence to real-world practice.
Hello, my name is Graham Ogle, and I manage the Life for a Child program, and I'm also an adjunct professor at the University of Sydney in Australia. Insulin is needed for survival in type 1 diabetes. The right to healthcare is enshrined in international law, and insulin is universally recognised as an essential medicine. Sadly, insulin availability and cost remain a problem in many lower income countries, and even in some higher income countries. But children and adults with type 1 don't just need insulin. They will also die if they can't access adequate diabetes education, skilled medical care, and the ability to monitor blood glucose. These can be more expensive than insulin. Families face terrible choices. Do they care for the child with type 1 or let that child go so they can pay school fees for the other children? If care can't be afforded, these young people die of hypoglycemia or ketoacidosis, or they remain chronically unwell and have difficulty completing their education and finding marriage partners, and then frequently develop early and devastating chronic diabetes complications. Now, where possible, people with type 1 diabetes should be provided with comprehensive, guidelines-based care. Too often, though, minimal care, with enough insulin to stay alive and little else is given. This commission promotes the concept of intermediate care, which is adequate human insulin in a basal bolus regimen, self-blood glucose monitoring, diabetes education, and HbA1c monitoring. This level of care has been shown to lead to rapid increases in numbers of young people alive with type 1 diabetes in lower and middle income countries. The Commission determined in a conservative estimate that 14,466 children and youth under 25 years die of type 1 each year around the world. If at least intermediate care was available for all of these, 8,369 deaths could be averted. And this is just talking about when they're young. With intermediate care or better, hundreds of thousands more adults with type 1 diabetes could avoid terrible complications and losing decades of their life. No child or young adult should ever die of diabetes. Thank you.
Hello, everybody. I am Dr. Juan José Gagliardino from Argentina, and I'm going to present evidences of the quality of care provided to people with diabetes in the region of Latin America. And for that purpose, I am going to present data from a study with 2,500 patients with type 2 diabetes. 90% of our diabetes population has this type of disease, attended by mainly specialists, diabetologists, and also some well-trained general practitioners. And the result that we have in those patients treated with oral anti-diabetic drugs is 66% glycated hemoglobin was on target. But unfortunately, as soon as we introduce insulin, that means in combination with the oral agents or alone, these figures fall down to 30% or even less. That means that unfortunately, our group is not providing a reasonable insulin regimen to cope with the targets recommended by the guidelines. In addition, we have some evidences that also we can improve this quality of care. And we did focus on the primary care level. Why we did that is because the first contact between the community and the healthcare system is the primary care level. And then we have to be sure that we can get a good early diagnosis and appropriate treatment from the beginning. In this condition, we introduce some changes in the education. We provide education from university courses to physicians, to nurses, and to people with diabetes. Why the latter group? Because we need these people working and playing an active and efficient role in the control and treatment of their disease. Otherwise, we are not going to cope with the problem. In addition, we introduced some changes in the management things. For example, patients that were waiting in the waiting room before getting in contact with the medical care, they fill a questionnaire, a simple one, the FINRISK, to identify those people with high risk of developing diabetes. And then we can, after the identification, provide the appropriate treatment to prevent development of the disease. In addition, before the patients come for the next appointment, one before, the call center make a phone call and remind them that they have to attend the consultation. And in this way, we have cut it down the desertion 48% to 28%. That means improving quite a lot the possibility to provide the good care. In addition, what happened with the indicators? Glycated hemoglobin 1 year after, blood pressure, and the values of lipid profile improve and attain the target values recommended by international and local guidelines. That means that if I have to recommend something to improve quality of care, I said, focus on the primary care level, use education, diabetes education at every level, not only at the professionals, but only at the patients with diabetes as well. And in that way, certainly you can improve the quality of care, you can prevent the development and progression of complications, and also you will increase the quality and quantity of life of people with diabetes, and certainly you decrease the cost of their care. Thank you for your attention.
Good afternoon. My name is Dinky Levitt and I come from Cape Town, South Africa, which is at the tip of Africa. And I'm here to speak about Africa, but that is a daunting process or a daunting prospect because there are more than 50 countries and small islands in Africa. Africa is not homogeneous. It is extremely heterogeneous. And even within a country, there is great heterogeneity between those who can afford care and those who cannot. The vast majority of Africa falls into the lower parts of low and middle income countries. And diabetes is an increasing problem in our societies here. There are large numbers of people who are not diagnosed. There are large numbers of people who don't have access to care, and there are large numbers of people who do not have adequate control. One of the major problems facing Africa is poverty. It is grinding poverty and lack of access. So many people are not able to afford the medication. They do not have access to safe spaces to exercise, particularly in the urban areas. And they do not have access to healthy food. The cheapest food options are the most unhealthy in our continent. There is a real challenge and an opportunity for governments and funding agencies to change the spectrum, to change the picture for diabetes in the same way as they changed the picture for HIV and TB. We need to have 90% of people with diabetes knowing that they have the condition, 90% knowing that they are on receiving therapy. And when I'm talking about receiving therapy, it's not just medication. They need access to care. They need access to diagnosis, and they need access to care. And we know that the cornerstone of care for diabetes is self-management. And it is not just having a single healthcare provider, it is having a team of healthcare providers who range from people in the community, peer support, nurses, and to a small degree, doctors. This is what is needed. And we call on funding agencies and we call on governments to take note of the fact that diabetes is a new challenge in the world and it needs to be addressed rigorously in order to reduce the burden of diabetes on our society, on our individuals, and on our communities. Thank you.
I think the essence of this commission is that diabetes has become such a persistent and damaging problem worldwide that affects people, their families, health systems, economies, that we have to really think about the whole population when we tackle this problem. We have to think about not just people with diabetes, but what we can do to help people who are at risk, to prevent them from developing diabetes, and the whole population to prevent them from moving on to developing high risk. And I think that one of the key aspects of findings from this commission is that data really drives action. So in addition to really training and getting systems in order, we also think that we need good data systems throughout the world where they don't exist now to tell us really where the problems are, where to act, among whom, and what to do both in the short term and the long term. And we're really hoping that this commission will drive people that are in positions to make change in their communities and in their countries to really make all this happen.
我一直很快饿，然后我会一直很口渴，那感觉就很不舒服。
I was a bit disappointed when I came to know that I have started developing diabetes, because I was having family history of my father being diabetic. So, and I know that when you are having family history, you are having chances or risk of getting diabetes 30% to 50%.
A lot of the symptoms that I had and didn't realise that were associated with diabetes was, I was just feeding the diabetes because it was an unquestioned.
Doktor ada bagi saya ubat, tapi saya kononnya ubat tu tak perlulah. Kerana kita masih muda kuat kan, jadi ubat tu memang mungkin tak berkesan kot. Jadi saya pun tak ambil. Tapi bila saya kena jantung, doktor macam-macam cakap baru saya percaya. Jadi saya kena ambil ubat untuk kesihatan jantung saya macam tu.
I was shocked. Actually didn't believe it because I think I was thinking that it was type 2 and didn't really make the difference.
No fue sencillo. Tuve que aprender cuántos hidratos podía comer en el desayuno, el almuerzo, la merienda, la cena. Y un día me di cuenta que lo hacía casi mecánicamente.
It becomes part of your life, in so much that I'm calling him Mr. D, part of my life. Nothing I can do, yes. In family we've got positive people, we've got negative people, yes. Then you have to deal with all of them. It's like Mr. D, my friend.
Have a pamphlet on really what the symptoms are, because I believe a lot of people are, wandering around that have got diabetes and they don't know, as it's often referred to as, a silent killer. It may be minor symptoms to them, but, they're going to grow and grow and grow. And like anything, the earlier you diagnose something, the better off you are.
By cutting down the cost of treatment, foreign drugs, imported drugs, custom duty, taxes, that will help people to manage their diabetes very well. They can afford to buy costly medicines at cheaper rate.
比如说那个验血的针啊，还是我们要打的insulin啊，是不是可以稍微价钱再便宜点？
They need to educate people first of all, because I think generally most people don't understand the difference between type 1 and type 2, and there's a lot of misinformation, and also more government support and healthcare, like for the pumps, CGMs, and for things like that, and just getting more help. Don't judge people if they are type 1. Understand that they don't have type 1 diabetes because they've eaten too much sugar, because I think a lot of people believe that.
Hello, I'm Roy Holman, Emeritus Professor of Diabetes at the University of Oxford and one of the many commissioners who've helped Juliana Chan and Ed Gregg to produce the Lancet Commission on Diabetes report, which has just been published. It's my privilege to chair this live interactive panel discussion focused on the implementation of solutions to reduce the burden of diabetes and non-communicable diseases. We have 3 keynote speakers who will provide brief overviews relating to the Commission's 4 main recommendations from the perspective of the global organisations they represent. Once they've all spoken, I will ask them to answer your questions. Our first speaker is Bente Mikkelsen. Bente is a physician who trained as a gynecologist and obstetrician and holds a master's degree in health administration and management from the University of Oslo, Norway. She is the Non-Communicable Diseases Director at the headquarters of the World Health Organization, and her current focus is on achieving sustainable development goals through the reduction of premature deaths from non-communicable diseases. Bente.
Thank you very much, and thank you for inviting me. And I would also like to immediately say that it's an incredible piece of work that you launched in the middle of the night, and which I was so happy to also listen to your chair, Juliana Chan, today in the World Health Organization announcement of the Global Compact for Diabetes. So we have heard already that there are many, many reasons to focus on diabetes, and I think you have done a fantastic job in really pinpointing this. But I still think we need to repeat some of this. We already have 420 million people living with diabetes, and we know that these numbers are increasing rapidly. And from a World Health Statistics report earlier this year, this is the only of the non-communicable diseases that actually is increasing in premature mortality. So the last 10 years is actually a 5% increase. So it's going completely in the wrong direction. So that's one reason. The other one was, of course, mentioned very elegantly by Dr. Richard Horton about the syndemic, or the way I have put it, the deadly interplay between COVID-19 and diabetes. So we know that people are untreated, undiagnosed, and also unprotected, and I will come back to that because you have many preventive measures in your Commission report. But we see that people are at much higher risk of dying from COVID and also to become severely ill. So these are 2 main reasons to focus. The third reason is, of course, that it's 100 years since the discovery of insulin. And I have to say, when we speak about a society of innovation, it is a big question mark. How can it be that only 50% of the people that need insulin actually have access? How can it be that the prices are so high that it actually leads to poverty? And how can it be that we still have thermo instability? And I think we need to fix this. So coming back to your report, I think I have looked at it, and I think the pinpointing on the prevention side is extremely important, but also on the complexity. So of course, we all know that there are many causes and there is a complex nature, and we need to have comprehensive system level change and also societal measures to reduce the risk of diabetes. And as you probably know, WHO developed in 2013 the best buys. And I'm very happy to see that many of the things that you have based the report on is also very much aligned with the best buys. And the best buys is the cost-effective interventions that can be very useful in low-income and middle-income settings. I think the really compelling result from the Lancet report is the modeling, that are able almost to give a global price tag. And this is one of the things that have been so much discussed and requested for in the work of us developing a global diabetes compact. I also think that the individual lifestyle and lifestyle interventions that you have prescribed is not only for type 1, but also, of course, very relevant for type 2 diabetes. And as we have recognized as well, we have another tsunami, and that's the tsunami of obesity, both among children and adults. And many of the interventions you are speaking about is really relevant for this. So I think we need to continue to work together, and it's fantastic that this report comes out now. And I'm so extremely proud and honored that we can be seen as a trusted implementing part of this, I would say, journey. So just 2 words, I know I have just a limited time, but just 2 words about what we want to achieve with the WHO Global Diabetes Compact. And this is really to have one united voice, and everybody has said that today, also from the film we just saw. There is a need to strengthen the voices of people living with and at risk for diabetes. We need to mobilize resources, and as was said, we need to implement this as essential health services in the universal health coverage, and especially at the primary health care level. So this is what we want to achieve. So we are focusing on prevention, diagnosis, measurement and monitoring, quality care, and of course we share the vision of the reduction of risk of diabetes and ensuring that all people diagnosed with diabetes have access to quality care and treatment that is equitable, comprehensive, and affordable. So I'm sure I will get some questions, hopefully, but I am very, very happy to be with you today. Thank you so much for the fantastic work.
Bente, thank you for that. Our second speaker today is Andrew. Andrew is a physician who trained in Newcastle upon Tyne in the UK, and currently he's Professor of Medicine at the Universities of Manchester and Miami. He's a past president of the European Association for the Study of Diabetes, and now president of the International Diabetes Federation, as well as chairman of the European Alliance for Diabetes Research. He's been a previous editor of Diabetic Medicine and currently is the senior associate editor of Diabetes Care. Andrew.
Thank you very much, Rory. Good afternoon, good evening, ladies and gentlemen. The International Diabetes Federation, or IDF as I shall refer to it, is delighted to endorse and lend support to the Lancet Commission, and congratulations to all the excellent work from many of the people who I know and those who I don't know on this commission. As you know, tomorrow, November the 14th, is World Diabetes Day. This is the 30th World Diabetes Day, and this was started by ourselves together with WHO back in 1971 and was adopted by the United Nations in a resolution in 2006-07. This year, in line with the WHO, we have chosen to have our topic, the theme for this year, especially tomorrow, and that is the role of the nurse in diabetes, the year of the nurse and the midwife in diabetes. Of course, it is 200 years since the birth of Florence Nightingale, the founder of modern nursing, and nurses now account for more than a half of all global healthcare workforce. There is still a severe shortage of nurses worldwide. The diabetes specialist nurse plays really a pivotal role in diabetes care. Increasingly in many countries, the DSN, diabetes specialist nurse, is responsible for managing diabetes, screening for prevention and for the later complications. They are usually a key link between the person with diabetes and other healthcare professionals. They are integral to the delivery of effective care, and their support and management in the prevention of diabetes complications, and especially, as we've heard already, during the current pandemic of COVID-19, they've been essentially responsible in many ways for developing telemedicine as a way to manage people with diabetes that can't actually attend the clinic. So there are 2 ways I believe we can help and contribute to the Lancet Commission and their recommendations. The second one is closing the professional gap in diabetes. And I think, as I said here, the education that is offered by IDF through our IDF school, these are a large number of courses that are giving credit. They get credit from the European Council of Education. We've made these accessible free of charge this year to all healthcare professionals, especially we're encouraging diabetes nurses and educators. So these are accredited courses using electronic learning. Secondly is closing the gap in diabetes care. And I think the role of the diabetes specialist nurse is key in this regard, not only just in the hospital, but in the community. And what we really want to encourage in many low and middle income countries is that the nurses are not simply working in the hospital, but are key members of the diabetes team in the community. And as I said before, often a major form of contact between the person with diabetes and other healthcare professionals. So we really do encourage this. This is, as I said, the year of the diabetes nurse. 200 years Florence Nightingale. Tomorrow is World Diabetes Day, where we celebrate the role and encourage the inclusion of more nurses in diabetes care and education. But tomorrow is also, in the Hindu religion, Diwali, which is a festival of light. Florence Nightingale was the lady with the lamp. So let's take this as a message to take diabetes nurses and lift their role as a key member of the diabetes team. Thank you.
Thank you, Andrew. Our third speaker is Helen McGuire. Helen is a registered nurse who holds a Master of Health Science degree in Health Administration from the University of Toronto, Canada. She is now PATH's Global Programme Leader for Non-Communicable Diseases, helping to leverage PATH's capacity to advance prevention and care for non-communicable diseases in low-resource settings, focusing on diabetes amongst other conditions. Most recently, Helen led the establishment of the Coalition for Access to Non-Communicable Diseases Medicines and Products, launched in 2017 alongside the United Nations General Assembly. Helen.
Thank you very much, Rory. It's a real pleasure to be with everyone and quite a privilege to join the launch today. I want to add my voice to the other panelists and commend the co-chairs and the commission and the commissioners for their comprehensive synthesis of the evidence on diabetes to mobilize action and transform diabetes prevention and care. Thank you so much for this contribution. At PATH, we have taken a health systems approach to access to NCD prevention and care, focusing on integrating diabetes services into primary healthcare and out into the community. Community health workers and nurses play key roles in implementation, along with strategies to strengthen access to diabetes medicines and products. Today, I've been asked to highlight our efforts to close local data gaps in diabetes that are critical to continuously strengthen decision-making by people living with diabetes, by providers, and at the system level to plan, finance, and deliver evidence-based diabetes care. Across many low middle income countries, there are barriers to capturing quality data, from complex systemic issues to simply accessing data collection tools. We work with national and subnational governments to strengthen data quality and respect the need for systems to be interoperable and appropriate for the local digital health architecture. We strive to avoid duplication, excessive reporting requirements, and to maximize data use. So let me go through a few examples that consider the data systems, the data quality and data access at national facility and individual level. And I do want to recognize Access Accelerated for their support in the work, some of the work highlighted today. So first, of course, one needs NCD indicators integrated into national information systems to collect and visualize national NCD data. In Vietnam, the General Department of Preventative Medicine, the GDPM, is currently working with partners to develop an NCD health information system to track the disease burden. But the GDPM is eager to strengthen the utility of the system. They want to take it further. They're working with PATH to augment the NCD health information system to not only track burden, but also provide data to support people living with NCDs, primary healthcare workers, NCD program managers, regional and national decision makers, to foster a cohesive and efficient national NCD program that is driven by the needs of people living with NCDs. It's quite an exciting advancement. In Kenya, the Ministry of Health was concerned about the quality of NCD data within the DHIS2, their national information system. So together we have focused on 10 counties to strengthen data quality and data use, with a shared goal of institutionalizing best practice in NCD data management by 2022. We've ensured facilities have necessary service delivery reporting tools, training and supervision on data capture, establishing data review meetings to support continuous improvement and shared learning by facility and county leaders, and conducted data quality assessments with the national and county level ministries. These findings are shared and discussed with national, county, and facility leadership to develop improvement action plans. And it raises the accountability and emphasizes the value of diabetes and other NCD data collection and quality. Another area that's extremely important and was raised by Graham earlier was the supply management and availability of diabetes medicines and their associated health products. But it's very difficult to have accurate demand forecasting for these medicines and products if the data isn't accurate that's used to calculate. So the Coalition for Access to NCD Medicines and Products is working on this. We're working with NCD leads and chief pharmacists and experts to develop a tool to adapt for the paucity of data for diabetes and other NCDs and strengthen forecasting. And lastly, and I think most tragic, is the data gap that individuals living with diabetes, particularly those using insulin, have difficulty accessing. And that is one that Graham raised, the access to their blood glucose level. A key data point necessary to make insulin dose adjustments and avoid acute and chronic complications that can be deadly. And these blood glucose test strips, often they're not provided with insulin within the public system. They require individuals to purchase within private pharmacies. And it's very difficult to find strips to actually match the monitors that people have. So this is a critical need. And I know the Diabetes Compact is looking at this, and it would be very highly profiled as we go into the centenary of insulin. Safe administration of insulin means strips and syringes. So from our side, we need NCDs integrated into data systems. We need data quality that fosters trust in the data, and we need data access. And through this, we can foster a culture of data use for decision-making and priority setting. This cross-cuts so much of what we do in diabetes, and certainly is required to support integration of diabetes at primary care level. So with that, I'll close. I want to, again, thank the Commission for this wonderful report to support our work. It's so easy to get lost in the complexities of some of these challenges, but really it provides opportunity for innovation and collaboration, and the Diabetes Compact provides a new opportunity to do that. We look forward to applying these findings to our work, and we certainly look forward to working with others on this effort. Thank you so much for the time today.
Thank you, Helen. So we turn now to the questions that you're all sending in. Please do keep sending those. Bente, if I could come to you first. There's a question from Trudy, who I believe is on behalf of the UK Non-Communicable Diseases Working Group, saying, can processes being developed to build resilience to COVID-19, including vaccination, be used to concurrently raise awareness and diagnosis of diabetes, signposting to services which provide advice, treatment and monitoring?
Yes, I think the simple question to this is yes, because it is a really challenging time, but the COVID-19 has been as an X-ray. So we can see from all different stakeholders and governments that there is a real understanding of the need to build back better. So in the sense, this crisis is the best opportunity I think the non-communicable diseases and diabetes among them have. And we have, for the first time, developed operational guidance, both for the lockdown, but also now more and more guidance for the restoration. And I would add that what we have seen during the COVID is also a lot of innovation. For example, digitalization of the health system has suddenly become extremely popular and rapid. Telemedicine and also new access models to medicine, of course, more in the communicable disease field yet, but I think this will also be useful for NCD. So in this very dark period, I think we can see lights, we can see an engagement that we have never seen before. So we just have to really work hard and utilize this moment.
Thank you, Bente. Andrew, did you want to add anything to that? You're on mute, Andrew.
I would agree with everything that's being said there, and there have been enforced changes in diabetes delivery, certainly in hospital and in the community, which can be embraced as a way forward, so that it gives us some opportunity as well as many challenges. But I think the use of telemedicine, which has become absolutely vital in keeping contact with shielding patients, is a good example of this. But one mustn't forget the need for good clinical medicine. Now, I've run my diabetic foot service throughout the pandemic without the ability to do x-rays, without the ability to do blood tests. And it's the importance of good clinical medicine, listening to the person with diabetes and examining them carefully. That must never be overtaken by technology, but technology can help us.
Thank you. Helen, can we have your views?
Yeah, I would say that, as Bente mentioned, it does provide an opportunity. I think one of the opportunities is really looking at the needs of people in a more comprehensive way and looking at the combined essential services, looking at NCDs as part of the overall package of help that people deserve and require. And so that's one package of it. Let's ensure that when there's efforts being made for HIV, when there's medicines being delivered to the home by community health workers for HIV, that those people are also carrying NCD medicines. In addition, I think it does, of course, amplify the inequities across the health system and brings forward the stark reality that we are just not serving people living with NCDs as others are being served. And Bente mentioned this bringing forward in the previous session on the Global Diabetes Compact. And lastly, I would say that you know, we do need to continue to really strongly advocate and ensure that we're using this opportunity. I don't want to, you know, it is an opportunity to really push this forward and say, you know, we can't go on the way we have been, that we need investment and that we need to address the needs of those living with diabetes at the primary healthcare level and using community health workers, etc. So thank you.
Thank you, Helen. And so, Helen, if I could stay with you, we have a question from Patricia asking, what can we do to make the population more aware of the risk factors for diabetes? And how can we prevent or delay the onset of the disease? Should we begin the education in elementary school, beginning with basic education about health with increasing complexity as the individual completes public education?
Thanks. Thanks for the question, and that's an excellent point brought forward around the involvement of schools. And this is something that we've worked on, and there's some excellent work done in South Africa on this, in really engaging in schools and including physical activity, identifying what types of foods are available to children in schools, that it's healthy, and that there's not the promotion of unhealthy drinks and beverages, etc., within the school environment. I think in addition, as I mentioned in my brief comments, the important role of community health workers to really be bringing out the messages to people, to their homes, to where they work, to where they live. In Vietnam, we brought screening and educational messages out to beauty salons, to restaurants, to any place where we found people gathering, in the parks when they're doing their exercises in the morning. Because we need to, if people aren't aware, they're not going to be getting screened, and they need to know that they can access this screening in a cost-effective way that they can afford. If it's part of a very complex physical assessment, it takes too much time and too much money in some places to have those screenings. But we can bring those screenings to the community. We can bring them to where people live and work, and we can make this accessible, and therefore raising the awareness of both risks, prevention, and also disease status. Thank you, Rory.
Andrew, do you want to comment on that early education and its role in the prevention of diabetes?
I think it's vital, but it has to be matched with examples. For example, Helen mentioned in schools, and absolutely there should be education there, but the example should be set in encouraging people not to be driven to the school by their parents, but to walk. To encourage, as in many countries, to have cycle tracks, to encourage exercise, and to have sensible food, not the usual tuck shop food, in the school canteen. This is challenging, as you may remember, Rory. There was a few years ago, there was an effort by our Prime Minister to try and put healthy food into the schools, and this, one of our daily newspapers had pictures of mothers selling fish and chips through the railings to the children who didn't seem to like the high fiber food. So it's a big process, but it's very important. But another message is that we must take diabetes seriously. And there was a nice piece in the Sunday Times last year about a person with diabetes talking about his experience. And he wrote, "I thought heart disease was serious. Cancer is serious, but diabetes never felt serious to me, and now I only have one leg." And I think the message of prevention of diabetes and secondary prevention. If you have diabetes, screen for complications with primary, secondary, tertiary prevention, and that's what matters all the way, but primary prevention first.
Thank you. Bente, did you want to add to that?
Yes, very much so. I think, again, I would commend the Commission on focusing on education, and I would like to call it health literacy as well. And it's not only for individuals, it's for organizations and also for policymakers. And I think the good thing here is that we need to combine these with, prevention. And one of the most efficient prevention is, of course, as we all know, taxation of sugar-sweetened beverages, but also, of course, on alcohol. And all of these things are really increasing the obesity situation. So with taxation, we will do something good for the health. We will also be able to increase the revenues, which is needed if we really want to have UHC, including also diabetes and the medicines and technology to go with it. So I think it's really important that we have to focus on the management, but the prevention side is really, really important. And I think we need to put a lot of more efforts into health literacy for all different kind of levels. And if we would like to add, it's also if you apply a life course, as was said by, I think, Andrew, then you have settings that is available, which I think still is underused, from kindergartens through schooling, through even prisons, and to the homes for elderly. It is possible to really re-emphasize, and you called it data, Helen, to give people the opportunity to make choices, but also to make population-wide choices. Thank you.
Thank you, Bente. So, Andrew, if I could start with you for this next question. I think there is a recognition from Helen that the syndemic between TB and diabetes is also very important. Very few TB programs in low-income countries screen for diabetes. So the question is there a role for integrated COVID, TB, diabetes, potentially blood pressure and HIV screening? So total screening plan, what do you think?
That's a tall order, but in principle, absolutely, absolutely. Of course, we're talking about very different conditions here. COVID is an acute infection, which has severe impact on people with diabetes should they catch it. It doesn't appear that they're at greater risk to catch it, and the younger people do better. Tuberculosis is a chronic disease, which is still prevalent, as the questioner mentions, in many parts of the world. And screening for TB, it definitely could be combined with another chronic disease, diabetes, or condition, I should say. As for HIV/AIDS, and as was said at the beginning, the programs for HIV/AIDS have been highly effective, and people are frightened of AIDS. But unfortunately, there's still the feeling that diabetes is just a touch of sugar, which cannot be true and is not true. And we need to change the public perception, but also the healthcare providers' perception as the diabetes as the pandemic of the 21st century.
Thank you. So, Helen, there are several questions in relation to this, looking at screening opportunities. Can you add to the discussion?
Sure. From the integration perspective,
The idea that we screen for multiple diseases when we have the opportunity, when we encounter patients, I think that's the question, not being sort of single-minded with our one topic.
Yes, exactly. Yeah, absolutely. And I think, again, this brings, COVID has brought forward a new opportunity to relook at this. It is something that we haven't really maximized the potential yet, that we can bring more comprehensive care to people. We know that people don't come with one disease, that they come with several comorbidities, and we need to realize that and address that. We can't increase their indirect costs, making them go to different places to receive different screenings. They need to receive it at once. And there's also the interplay, of course, between diseases like TB and diabetes, those with diabetes being much more likely, 3 times more likely to contract TB. So important to really take that opportunity and integrate. If you think of integration as a continuum from co-location to coordination to co-location to full integration, wherever we can sit along that continuum with the resources that are in play and the willingness across the different areas, we need to really really take that on board and maximize that as much as we can. It's to the benefit of the person living with these diseases, and it's more efficient.
Okay, Bente, did you have a comment for this poly-screening effort?
Yes, and I think it's totally realized, and this is part of the strengthening of the primary healthcare. So the WHO will come out with a guidance for integration in primary healthcare across the program. So it means both HIV/AIDS, TB, and also all the NCDs and mental health. And this is coming out next year, because it's easy to say, it's not that easy actually to do. And I want to add one more thing, because I was mentioning taxation as one of the most efficient public health interventions, which also increase the revenue. But I think in this setting, when you talk about tuberculosis and diabetes, I want to mention that during our consultation, one of the things that I would say many people were still very surprised of was tuberculosis and diabetes as comorbidities. And why is it very important to mention this now? And it is for another reason, because we also need international funding. And the Global Fund, as you know, are now developing their second or their next strategy. And still, I have to say, NCD is not included. So this is also a golden moment where we need to make a case for NCD also and open up the global financing mechanisms like the Global Fund. So I think this is really a call for all of us to make this case and make it very convincing, which it is actually on the ground. Thank you.
Thank you, Bente. So, Andrew, if I could come back to you, we have a question from Shu Him asking what pharmacists can do to help in the rising diabetes crisis.
Yeah, I think pharmacists have a major role to play, and I'm delighted that one of our board of directors of IDF is a pharmacist. So they have a major role in education and in screening, and many pharmacists now offer screening for diabetes and also helping patients with their medications, dosage, blood glucose control. They're becoming an integrated member of the team, and I encourage this and implore other countries to really grasp the pharmacists and use them, because their knowledge is usually fantastic.
Thank you. Helen, can you comment?
No, I just repeat what Andrew had just shared. In Vietnam, as part of the Community for Healthy Hearts project and the expanded diabetes project, this is something that networks of pharmacies are taking on, an expanded role. And also in Kenya, there's been interest with the pharmacy group there, HOPAC, in looking at the expanded role of the pharmacist and the important work that they can do, as Andrew said, to both screen, monitor, educate people living with diabetes in a very accessible way.
Bente, have you included pharmacists in your efforts to reduce diabetes?
So I think this makes an opportunity for me to mention another learning point from COVID. We've talked about telemedicine. The other main mitigation strategy is actually task shifting. This is something we have discussed many years and very difficult to implement. Suddenly now during COVID, it came as a necessity. So pharmacists, and we've talked about nurses, we also talk about community health workers. So I think what we should do now is to really try to learn from the situation that came out of need and try to see if we can, streamline this. So pharmacist is very welcome. And of course, I totally applaud also Andrew's praise of the nurses. And we celebrate with you for diabetes nurses as well. Thank you.
Thank you. Okay, so Helen, if I can come back to you. We have a question asking what are the opportunities for preventing childhood obesity and gestational diabetes? Well,
our opportunities are to make a difference, to really get the prevention messages out and make them accessible to those target audiences. I think that we can be doing more work again in collaboration with the maternal child health and nutrition programs that are done. How can we work more closely with programs that are already running in maternal child health and nutrition to raise awareness of gestational diabetes and the prevention there. I think around obesity, we talked about school health, and a lot of the initiatives there are most important to reach children in their young years and shape their eating patterns at a young age. So I think I'll leave it at that. Thanks.
Thank you, Helen. Bente, can you add to that?
Yes, with pleasure. So I think it was Ed saying, which was also an echo from all the consultations we have had, that we need to have global targets. We saw that sort of the 90-90-90, and now we also have global targets for cervical cancer. And this is something I think we need to really define for diabetes, because this is much easier to understand. And one of the ideas is actually to use childhood cancer as a tracer. It's not the only thing that we will focus on with prevention, but exactly there is already a target. And I think this is also very well sort of coming together with the life course education, health literacy. And this I think is a great idea, and it's also super necessary. As you have seen, it's really a tsunami now of obesity. And we do a stock take in WHO to see what can we do better to actually reach the 1 billion more people covered. And one of the things is childhood obesity and obesity as one of the preventive care. On the gestational diabetes, I would say that there is still a call for a lot of research, and especially implementation research in the area of diabetes. So we have done a quick mapping of things that need to be addressed. And one of them, I think, is better guidance for gestational diabetes and more clarity, what is the right choices. So I think this is, we just have to admit, we don't have all the answers here, and it's a list of other things we don't have answers for. So let's be transparent on this and mobilize our academic colleagues to work on this. Thank you.
Thank you, Bente. I'm afraid our time is up, but I would like to thank all of our speakers for their excellent responses, for those who had sent in questions, and I'll hand back now to our chair to close the session. Thank you.
Worldwide, 463 million people have diabetes, with 80% coming from low and middle income countries. In 2019, 4.2 million people died as a result of diabetes and its complications, although many of these deaths could have been prevented. The diabetes epidemic is driven by factors beyond health, including poverty, inequality, aging, poor nutrition, food insecurity, low educational attainment, and environmental pollution. By protecting our environment, changing our practice, and empowering our communities, we can reduce the burden of diabetes as a root cause of non-communicable diseases. The diabetes epidemic is a calling that concerns all of us, as every one of us has contributed to the ecosystem in one way or another to fuel this epidemic. As such, all of us have the collective responsibility to rise to this challenge, to sustain our environment, and to use our finite resources to preserve humanity. The global challenge of diabetes transcends political, economical, social, and technological domains. Whether you are a policymaker, a payer, a planner, a practitioner working in the private or public sector, an industrialist, a patient, or a lay person, you will find messages and recommendations relevant to your aspiration and practice in this Lancet Commission report. Join us in this all-out fight against diabetes and non-communicable disease by transforming diabetes care and lives with diabetes. If you have any idea for collaboration, call us, and thank you.